Today we will discuss about the aberrations in female puberty. Puberty is a complex biological sequence and aberrations generally fall into three categories. One, timing, either it's too early or too late, or in the sequence where it is out of order, or in the morphology with atypical physical development. So evaluating these needs a mix of physical assessment, bone age mapping and hormonal assays. So let's see the aberrations in timing. One is precocious, defined as the onset of secondary sexual characters before the age of 8 in girls. It could be central or peripheral. Central is GnRH dependent. There is early activation of the master switch in the brain. It follows the normal sequence but starts too early. Peripheral is GnRH independent. Excess estrogen from outside the brain pathway is the reason. It could be ovarian cyst adrenal tumors or environmental exposure. Delayed puberty is the absence of telarchy by 13 years or the absence of menarche by 15 years or 3 years after the telarchy when the menstruation doesn't start. Constitutionally say delay is another one which is very common and they are called late bloomers. They often have a family history. Bone age is typically delayed. Hypergonadotropic hypogonadism, the brain is signaling but the ovaries are not responding. The classical example is Turner syndrome. Next comes an aberration in the sequence of morphology. Premature adrenarche is very common. Appearance of pubic and axillary hair before the age of 8 years without breast development because usually telarchy is the first. It is due to the early awakening of the adrenal gland. It is often benign and is usually a precursor of PCOD. Benign breast abbreviations are juvenile hypertrophy of the breast due to massive overgrowth and sometimes fibroadenomas complicating. Occasionally there can be Mullerian agenesis or the MRKH syndrome where this is structural aberration where the girl undergoes a normal puberty, breast and hair, but because her ovaries work fine, but she never starts the period because the uterus and vagina has failed to develop properly. Now, how to evaluate these things? A detailed clinical approach and clinical evaluation is usually there. So, it's usually a diagnostic ladder. First, you do the physical examination. The first in that is Tanner staging, categorizing breast and pubic hair development from Tanner stage 1, which is pre-pubertal, to 5. Then look at the growth velocity, plotting the height on a curve. A growth spurt in a 6-year-old suggests it is precocious puberty. Then look for stigmatas, looking for capillary spots to diagnose McCune-Albright, looking for webbed neck to diagnose Turner syndrome. Followed this is the phase 2, where we go for more objective assessment. Bone age radiography, usually the non-dominant hand, the wrist with the hand is taken. So if the biological age is of a 7-year-old child has a bone age of 11-year-old, her body is rushing towards closure of growth plate, which means that his adult stature would be low. And phase 3 is the intense laboratory investigations, which are the hormonal panel, which usually include FSHLH, estradiol and DHES. A combination of high FSHLH suggests the brain is driving the process and a low FSHLH says that the brain is, with high estrogen says that it is ovarian or adrenal source. Pelvic ultrasound is always should be done to measure the uterine volume. Look for follicles or tumors. A pear-shaped uterus indicates significant estrogen exposure has happened. And of course, when you consider central precocious puberty, you usually go for an MRI to pick out hematomas near the pituitary gland. So this is how usually you approach aberrations in female puberty.